Welcome everyone to our Davidson Gastroenterology course. Today our lecture topic is presenting problems in gastrointestinal disease. We will discuss dysphagia, dyspepsia, acute gastrointestinal bleeding, malabsorption and vomiting accordingly. So let's proceed. Our first topic is dysphagia. So what is dysphagia? Dysphagia is defined as difficulty in swallowing. So we can divide, there are two types of dysphagia. One is oropharyngeal dysphagia and another is esophageal dysphagia. Oropharyngeal dysphagia means the problems at the initiation of swallowing and the problem present at the pharynx and upper esophageal sphincter. And esophageal dysphagia means the food is sticking after swallowing in the pharynx or esophagus. So both of oropharyngeal and esophageal dysphagia may further classified into structural causes and propulsive causes. Structural means obstructive causes, or propulsive means neurological causes. When solid food stuck into the esophagus, the cause mainly due to structural or obstruction, and when both liquid and solid food obstruct, the cause may be neurological. So we will discuss first oropharyngeal dysphagia. Oropharyngeal dysphagia may cause structural causes. There are structural causes and neurological causes. Structural causes are tonsil, paratonsillar abscess, Zenker's diverticulum disease, and neurological causes are due to stroke, Parkinson's disease, or motor neuron disease. Motor neuron disease mainly occurs due to demyelination of the nerve, and there are also multiple sclerosis may be a cause, and myasthenia gravis. So let's talk something about myasthenia gravis. We know that in our nerve endings there are neurotransmitter termed as acetylcholine. When in the muscle there are muscle receptor for acetylcholine. When acetylcholine released from the neurotransmitter vesicle, they act on the receptor and causes muscle contraction. But as there is in myasthenia gravis, there is autoantibody present. This autoantibody cover or masking on the receptor termed as MuSK mask. So the acetylcholine can't work on these receptor. So muscle are not response are not occurs in acetylcholine. So our one kind of esophageal muscles become one kind of paralyzed. Our next topic is esophageal dysphagia. Esophageal dysphagia causes are structural causes in carcinoma. Stricture may causes due to gastroesophageal reflux disease, radiation stricture in case of carcinoma patient, and due to obstruction of foreign body. There are in the esophagus there are three anatomical locations where foreign body can stuck. One is cricopharyngeal muscle in the place of carina. Carina is the place where right bronchus cross esophagus, and third one is where diaphragm cross esophagus. And the neurological cause is achalasia. So what is achalasia? Achalasia means impaired relaxation of lower esophageal sphincter. Lower esophageal sphincter. So when the esophagus and the lower esophageal sphincter opens, can't relax, there is a stricture may present, or fibrous tissue causes a stricture. So there is a in our barium swallowing we can see a dilated esophagus. We can see a dilated esophagus, and there is a characteristical bird beak's appearance may find. Bird's beak appearance may find. So the esophagus is dilated, and there is non-acidic regurgitation occur. Non-acidic regurgitation occurs. So due to impaired sphincter, the food content can't go to the stomach, so non-acidic regurgitation occurs. So this is the characteristical symptoms of achalasia. So our next topic is how to investigate. So dysphagia may present with food sticking after swallowing with or without regurgitation, or difficulty initiating swallow with or without choking or aspiration. So in case of food sticking after swallowing with or without regurgitation, that means the causes is esophageal dysphagia. So in esophageal dysphagia we will do endoscopy and biopsy, and the causes are maybe stricture, maybe esophagitis, or maybe dysmotility. In stricture there are two kind of stricture. One is benign causes and another is malignant causes. In benign causes, there may be peptic fibrous ring due to eosinophilic esophagitis, or maybe due to drugs, which is bisphosphonate. And in malignant causes, there may be carcinoma of the esophagus, carcinoma of the stomach, or maybe extrinsic causes which may be present in any mass or any kind of shifting of mediastinum. And esophagitis, there may be causes due to peptic ulcer, or esophagitis due to candidiasis, or eosinophilic esophagitis may occur. And next one is dysmotility. We'll do manometry or barium swallowing, and the causes is achalasia or non-specific motility disorder. If difficulty initiating swallowing, so we'll do it indicates oropharyngeal dysphagia, and we'll do video fluoroscopic swallowing assessment and neurological investigation. So the most important neurological disease may causes bulbar palsy, pseudobulbar palsy, or myasthenia gravis. Okay, now we will discuss about dyspepsia. Dyspepsia means any symptoms that arise due to any pathology in gastroduodenal region. So it is a complex of syndrome or symptoms that arise due to any pathology in gastroduodenal region. Dyspepsia commonly associated with heartburn, regurgitation, acid reflux, and water brush. But these four are not again I am saying these four are not dyspeptic spectrum. They are not in the set of dyspeptic spectrum. So we need to know what is dyspeptic spectrum. So dyspepsia may be classified into two groups. One is functional and another is secondary cause. About 70% is functional dyspepsia. What does functional dyspepsia means? Means we will never find any particular cause for dyspepsia. No tumor or no ulcer will present, and about 30% in case we found cause, and among them mainly peptic ulcer disease is the highest. About 95 to 98% is peptic ulcer disease. Now we will talk about dyspeptic symptom or dyspeptic spectrum. Dyspeptic spectrum is about four symptoms: early satiety, postprandial fullness, epigastric pain, and epigastric burning. First of two, early satiety and postprandial fullness is related with meal, and they are termed as postprandial distress syndrome. And last two, epigastric pain and epigastric burning sensation, these are in the epigastric pain syndrome. When both of them, means both of postprandial distress syndrome and epigastric pain syndrome, both of them last for more than 3 months, and the onset was 6 months ago, and when we will find ultrasonography and endoscopy report negative, means no peptic ulcer disease, then we will classify it as a functional dyspepsia. So in functional dyspepsia we need to have all of this dyspeptic spectrum. But heartburn, regurgitation, acid reflux, water brush, they are associated with commonly associated with dyspepsia, but they are not truly dyspepsia dyspeptic spectrum. Dyspepsia may be present with heartburn, dyspepsia may be present with regurgitation, dyspepsia may be present with reflux, acid reflux, or water brush, but about 70% of dyspepsia is have no findings. Either they have early satiety, postprandial fullness, epigastric pain, or epigastric burning sensation. First of two means early satiety and postprandial fullness, which is called postprandial distress syndrome, and epigastric pain and epigastric burning, which is termed as epigastric pain syndrome. Both of them present more than 3 months, and onset was 6 months ago. And when ultrasonogram and endoscopy reveals no peptic ulcer disease, then we will term it as a functional dyspepsia. And if we find any ulceration, any erosion in the gastric mucosa, then it is peptic ulcer disease, and it is the secondary cause, means that is the under of 30% dyspepsia causes. So next we'll know about the cause of dyspepsia. Upper gastrointestinal disorder, peptic ulcer disease is the cause, acute gastritis, gallstone is a cause, esophageal spasm, non-ulcer dyspepsia, irritable bowel syndrome is a upper GIT disorders. Other gastrointestinal disorders are pancreatic disease like cancer, chronic pancreatitis, colonic carcinoma, hepatic disease like hepatitis and metastasis. Systemic disease are renal failure, hypercalcemia, and the drugs which may cause dyspepsia are NSAID, glucocorticoids, and others causes are anxiety, depression, alcohol, iron and potassium supplements, and digoxin. Mainly digoxin toxicity causes dyspepsia. Now, some alarm features in dyspepsia. If dyspepsia present with weight loss, anemia, vomiting, hematemesis or melena, dysphagia, palpable abdominal mass, these are the alarming feature in dyspepsia. We need concern about that. So now, how we will investigate our dyspepsia? If first we will need to ask, is there any alarm features with dyspepsia? If yes, then urgent endoscopy and reveal the cause. And if there is no alarm feature, then if the age is 55 years, more than 55 years, or less than 55 years, if the age is more than 55 years, then again urgent endoscopy and reveal the cause. But the age is under 55 years, then we will go for test for hepatic Helicobacter pylori bacteria by serology, stool antigen, or C13 carbon 13 urea breath test. If the Helicobacter pylori is positive, then we need to Helicobacter pylori eradication. After the course, we need there is triple therapy for Helicobacter pylori. If there Helicobacter pylori after triple therapy or quadruple therapy, if symptoms resolve, then we need no follow-up. But if symptom persists, then we need endoscopy to disclose any erosion or peptic ulcer disease or any ulcer. And if Helicobacter pylori is test is negative, then treatment is symptomatically and consider other diagnosis. Okay, so that was for dyspepsia. So now our topic is vomiting. What is vomiting? Vomiting is a complex involving both autonomic and somatic neural pathways. Synchronous contraction of the diaphragm intercostal muscle and the abdominal muscle raises intra-abdominal pressure, and combined with relaxation of the lower esophageal sphincter results in forcible ejection of gastric content. So what are the causes of vomiting? Causes of vomiting are psychogenic central nervous system disorder, which includes vestibular neuritis, migraine, raised intracranial pressure, and meningitis. Raised intracranial pressure have the symptoms of headache, vomiting, and papilloedema. These three symptoms are termed as combinedly Cushing triad. Cushing triad is a symptomatic triad which are often found in when intracranial pressure is raised. Similarly, there is another term which is Cushing reflex. So, additional topic, Cushing reflex is bradycardia, hypertension, and respiratory depression. Okay, I'm writing here. Respiratory depression are termed as bradycardia, hypertension, and respiratory depression are termed as Cushing reflex. This is another term. Okay, then another causes, gastroduodenal causes are peptic ulcer disease, gastric cancer, and gastroparesis. Sometimes Staphylococcus aureus and Bacillus causes food poisoning, that is the gastroduodenal cause or gastroparesis for vomiting. Uremia and acute abdominal causes are appendicitis, cholecystitis, pancreatitis, and intestinal obstruction. And there is a alcoholism, drugs. Some drugs causes vomiting. Digoxin toxicity is one of them. And infections with fever. Infections with fever are hepatitis, gastroenteritis, and urinary tract infection are causes vomiting. Metabolic causes are diabetic, ketoacidosis, and addiction disease. The reason of addiction disease are unknown, but here the mainly causes are identified as electrolyte imbalance are the main cause for vomiting. We know that decreased amount of sodium in our body causes vomiting, and hypoglycemia also causes vomiting. Hypoglycemia that leads to diabetic ketoacidosis leads to vomiting. So this was all about vomiting. We will discuss about malabsorption. Features of malabsorptions are diarrhea or steatorrhea, when bulky, pale, and offensive foul-smelling stool that floats in the water is called steatorrhea, which is due to fat malabsorption, and weight loss, anemia are the key features of the malabsorption. Patient may also complain of malaise or lethargy. Now we'll discuss the possible physical consequences of malabsorption. Night blindness due to vitamin A deficiency, and anemia occurs due to iron, folate, and vitamin B12 deficiency. Angular stomatitis, glossitis occurs due to iron, folate, and vitamin B12 deficiency. Bleeding gums occur due to vitamin C deficiency. Follicular hyperkeratosis occurs due to vitamin A deficiency, and acrodermatitis enteropathica occurs due to zinc deficiency. Koilonychia due to iron deficiency. Paresthesia and tetany occurs due to calcium and magnesium deficiency, and clubbing also occurs. Osteomalacia rickets occurs due to calcium and vitamin D deficiency. Muscle wasting occurs due to protein deficiency, and Proximal myopathy occurs due to vitamin D deficiency, peripheral neuropathy, vitamin B12 deficiency, peripheral edema, hypoalbuminemia. All of these occurs due to mainly we can see that micro or macro minerals, vitamins deficiency, and carbohydrate, protein, or fat malabsorption or maldigestion causes these kinds of physical consequences. And also lethargy and depression occurs, distension, steatoria, and watery diarrhea occurs, poor wound healing due to vitamin C, protein, and zinc deficiency, purpura and bruising occurs due to vitamin C and K deficiency. Here are some pictures about acrodermatitis enteropathica. Sometimes it may be confused with psoriasis, but the differentiating point is in case of psoriasis, there will be a silver dry scale on the red above the red erythema. Okay, but here is only reddish erythema damage, surface epithelium surface damage is seen, but no whitish or silvery scale are seen. So that is the differentiating point. And another is follicular hyperkeratosis. In the follicle of body here, there will be keratin deposition occurs. So now we will discuss something about some topics on malabsorption and maldigestion. Malabsorption is mainly when our enzyme, when our the food particle and enzyme are okay. Enzyme activity is okay. They will break down the food particle into their absorption unit very well. But due to mucosal damage, the food or the food particle can't absorb, or the enzyme activity, the mucosal enzyme activity or channel are destroyed. So food can't absorb into the epithelium cells. So this is called malabsorption, and so due to this malabsorption, we lack of carbs occurs, protein absorption decreased, and also fat absorption is also decreased, and other micro and macro minerals absorption deficiency occurs. And maldigestion means mucosal surface is not damaged or okay, but the defect in enzyme activity. So food particle can't transform into absorptive unit. This is called maldigestion. So the difference is malabsorption or maldigestion in two way. One is enzyme activity is okay or not, and mucosa is damaged or not. If enzyme activity is okay but mucosal surface damage, then it is called malabsorption. And when mucosal surface is okay but enzyme activity is defect in enzyme activity, so it is termed as maldigestion. Now we will discuss some points on celiac disease, which will help us in later slides. Celiac disease is an autoimmune disease. Celiac disease is an autoimmune disease. So in our food charts, there are some materials like there are food items such as wheat or flour. They contain gluten, and when enzyme activity occurs on gluten, gliadin is a unit which is super aminogenic. So this gliadin, when passed through the mucosa, they are detected by antigen presenting cells which are present into the mucosa. These antigen presenting cells target gliadin as a foreign particle, and they activate T helper cell. Then T helper cell release a lot of cytokines. These cytokines active mainly plasma cells, and plasma cells are converted into antibody. These antibody, when attached to the mucosa, and they results mucosal damage. So due to mucosal damage, absorption is decreased. Here there are some kinds of antibody are produced in celiac disease, which is TTG. It is immunoglobulin A type antibody, and another one is DBP, which is immunoglobulin G type antibody. We will need them later. Okay. Now, routine blood test abnormalities found in the malabsorption. Hematological findings will be microcytic anemia due to iron deficiency. Macrocytic anemia occurs due to folate and vitamin B12 deficiency. Increased prothrombin time occurs due to vitamin K deficiency. And biochemistry abnormalities are hypoalbuminemia, hypocalcemia, hypomagnesemia, hypophosphatemia, and low serum zinc. So what are the pathophysiology of malabsorption? There are three types of malabsorption. Intraluminal maldigestion. Intraluminal maldigestion means the digestive enzymes deficiency or inactive. Bile juice may be inactive or deficiency. Pancreatic or intestinal enzymes may be defective. Inadequate solubilization occurs of food particles, so hydrolysis of nutrients can't occur properly, and sometimes overgrowth of the bacteria also causes maldigestion, intraluminal maldigestion. Okay, then mucosal malabsorption. In this case, damage the small intestinal epithelium. So mucosal malabsorption is due to damage the small intestinal epithelium, decrease surface area, so it's depleting brush border enzyme activity. There are three types of small intestinal epithelium damage. Lesions are seen classified into three types: diffuse specific, which is seen in Whipple's disease; patchy specific in Crohn's disease or lymphoma or infectious causes; diffuse non-specific damage, which is seen normally in celiac sprue or tropical sprue or autoimmune enteropathy. Here we can see a diffuse but specific mucosal damage, which is found in Whipple's disease. So intraluminal maldigestion is actually this. The defect intraluminal maldigestion is that mucosal surface is okay, but enzyme activity is defect, and mucosal malabsorption is when the surface area of the epithelium is damaged. So there is decreased surface area and depleting brush border enzyme activity. Third cause is post-mucosal lymphatic obstruction. Sometimes prevent uptake and transport lipid. In this case, mucosa is okay and enzyme activity is also alright, but after absorption, the absorbed lipid can't transport or can't uptake by the lymphatic due to obstruction. So due to lymphatic obstruction, increased vessel pressure, and which leads to protein losing enteropathy. So how we will investigate a malabsorption case? Malabsorption case will first, when we suspect a malabsorption, clinical features of steatorrhea is present, then we will do blood test: urea, electrolyte, immunoglobulins, calcium, magnesium, complete blood count, clotting time will be decreased, clotting time will be increased, albumin is low, folate deficiency will occur, vitamin B12 deficiency will occur, and celiac antibodies. What are the celiac antibodies? Were in our previous slides: T, T, G, which is immunoglobulin A type, and D, B, D, B, P, which is immunoglobulin G type. Okay, so if we find celiac antibody or this deficiency, will treat the underlying cause. If then we will investigate the small intestinal abnormalities. We can do duodenal biopsy, barium studies, or small bowel MRI, fecal calprotectin, lactulose or glucose hydrogen breath test. It is actually the patient who have lactose intolerance. The lactose intolerant patient, they produce lactic acid. They will produce lactic acid. So pH will decrease. pH will be decreased, means more acidic. So we can find by hydrogen breath test. For hydrogen breath test. Okay. The investigate for the pancreas will be pancreatic function test. Fecal elastase will be can assay, and ultrasonogram and CT scan or and MRCP can be done. Consider bile salt malabsorption. It is the last. If everything is okay, then we will consider bile salt malabsorption. CHCAT scan can do, and serum 7-alpha hydroxycholesterol can be done due to find bile salt malabsorption. Okay, now we will discuss about gastrointestinal bleeding. There is a ligament called the ligament of Trees. The attachment of ligament of Trees divided the gastrointestinal tract into two parts, including esophagus, stomach, and the duodenum is termed as upper GI tract, and beyond the attachment of the trees, ligament of Trees is termed as lower GI. So bleeding from esophagus, stomach, and duodenum is termed as upper GI bleeding, and bleeding from jejunum, ileum, large intestine, and rectum is termed as lower GI bleeding. So now we will discuss about acute upper GI bleeding. The causes are esophagitis, peptic ulcer. This is the most common cause. And peptic ulcer occurs most commonly by the Helicobacter pylori bacteria, which is a gram-positive bacteria, and NSH-induced ulcer occurs. Vascular malformation can occur, and aortoduodenal fistula occurs. And another second most common cause is esophageal varices. When the cirrhosis occur, liver cirrhosis occur, or portal hypertension occur, we know the anastomosis of esophageal vasculature may become dilated, and erosion on this vasculature causes severe bleeding and hematomesis. The Mallory-Weiss tear is a retching or longitudinal tearing of mucosa at the esophagus and stomach area. The junction between the esophagus and the stomach, there is a longitudinal tearing occurs due to severe vomiting or severe coughing or retching, and from this place bleeding can occur. Cancer of stomach, esophagus, or gastric erosion causes due to NSAIDs or alcohol may cause also GI bleeding. This is Mallory-Weiss tear. We can see the junction of esophagus and stomach. There is a longitudinal tearing, and bleeding from this area causes upper GI bleeding, or hematomesis or melena can occur. So how we will do our clinical assessment? The patient may present with hematemesis. Hematemesis means vomiting of blood. Hematemesis is red with clot when bleeding is rapid, and profuse and coffee ground when less severe. Because the amount of blood is little that it may go under oxidation, and the color becomes coffee ground. But if the bleeding is rapid and profuse, the hematemesis is red and clotted. Next is syncope. It is caused by hypotension when intravascular volume depression. Actually, if the patient present with the hematemesis or melena, so what will happen? Blood volume will decrease. And if blood volume decrease, the plasma depletion will occur, so stroke volume will be also decreased. If stroke volume decreased, so what will happen? Cardiac output will also decrease, and it will causes mean arterial pressure decrease, and all of this ultimate result is hypovolemic shock. So patient will be present with syncope. Anemia will occur because of hematemesis and melena. Hemoglobin decreased, so RBC decreased, and patient present with anemia. Melena, passage of black tarry stools contain altered blood. Bleeding from upper GI tract, although hemorrhage from right side of colon is occasionally responsible. The characteristic color and smell of melena is results of the action of digestive enzyme of the bacteria on hemoglobin. Severe acute upper GI bleeding causes melena. Our next topic is the emergency management of non-variceal bleeding. Okay, so we'll discuss here non-esophageal variceal bleeding. So our first step is do large bore cannula, and we need to do initial clinical assessment of the patient. We'll check the circulatory status of the patient. Is there if severe bleeding occurs, it causes tachycardia, hypotension, and oliguria. The patient may be cold, sweating, and may be agitated. Seek any evidence of liver disease is present or not. Jaundice, cutaneous stigma of cirrhosis, hepatosplenomegaly, and ascites may be present in decompensated cirrhosis patient. So here we can assume the bleeding or hematemesis or melena occurs due to esophageal variceal bleeding or not. And we need to identify other comorbidity. CVS system, nervous system, and other system are checked thoroughly. Then we need to do some basic investigation. Basic investigations include full blood count. Chronic and subacute bleeding leads to anemia, microcytic hypochromic anemia, and if we find thrombocytopenia, may be a clue to the presence of hypersplenism in chronic liver disease. Urea and electrolytes. Electrolytes imbalance is showing the evidence of renal failure, and when we find urea rises in the blood, so raised blood urea is occur when severe bleeding. Why? Because in severe bleeding, some amount of blood is absorbed through the gut, and it is metabolized by the liver, and when the luminal blood are metabolized by the liver, it will elevate the blood urea. So elevated blood urea with normal creatine concentration is the indicate severe bleeding. Liver function test to exclude the causes of chronic liver disease, we need to do prothrombin time. It will also exclude or reveal the liver disease, or if the patient is under anticoagulated or not, and we need to do a cross match. Then we need to do resuscitation. First of all, we have to do intravenous crystalloid fluid should be given to raise the blood pressure with a 500 bolus. It's a very important SBQ. With a 500 milliliter bolus recommended over less than 15 minutes in hemodynamically unstable patient. In most of the patient, blood should be transfused when hemoglobin is less than 7 gram per liter. It would be 7 gram per liter. Okay, 7 gram per liter. Although transfusion should be considered at higher level in those with hemodynamic instability or ischemic heart disease. Oxygen, if the patient the saturation of oxygen is under 94 to 98%, we need to provide oxygen support. Antithrombic drugs. Individual presents with an upper GI bleeding while using antithrombic medication. If the patient take aspirin, it may be continue during upper GI bleed, or P2Y12 receptor antagonist, which is clopidogrel, should be temporarily stopped. So if the patient took aspirin, it may be continue, but if the patient took clopidogrel, it should be temporarily stopped, as well as warfarin also. Proton pump inhibitor therapy. Intravenous proton pump infusion should be given in non-variceal bleeding in individual who have a higher risk ulcer
post endoscopy. After endoscopy, if we find ulcer or any kind of ulcer in esophagus or GIT or duodenum, so common PPI and their doses for peptic ulcer disease is lesnoprazole, omeprazole, pantoprazole, rabiprazole, and intravenous infusion have omeprazole, pantoprazole, and esomeprazole. Most important is pantoprazole. So standard dose is for 40 milligram of once daily, and higher dose is also 40 milligram twice daily. And rabiprazole is 20 milligram once a daily standard dose, but higher dose is 20 milligram twice daily. And intravenous infusion is 80 milligram IV bolus followed by 8 milligram per hour for 72 hours. Endoscopy, we need to do endoscopy. So this should be carried out after adequate resuscitation, ideally within 24 hours. Patient with major endoscopic stigma of recent hemorrhage can be treated endoscopically by heater probe or endoscopic clips can be done, and we will give adrenaline or epinephrine into the bleeding point. It is when we do both heater probe and adrenaline, it is termed as dual therapy. Or we can do clipping and bind ligation to the vessels, and balloon tamponade is another option if all of these are failed, while arrangement are made for a transjugular intrahepatic protosystemic shunt, which is termed as TIPS. So we'll do TIPS when all of dual therapy or clips are band ligation fails, then we'll do TIPS. Then monitor the patient, radiology or surgery if need underlying cause. So we have to do this, and eradication. If the patient have H. pylori, so we need to do eradication, triple therapy or quadruple therapy. In the patient who have take NSAIDs, there I need to mention some things about NSAIDs. If the patient are under NSAIDs, it may be discontinued. We need to do discontinue, or we can suggest COX-2 selective drugs for the patient. Okay, but if the patient are taking aspirin, so here's if why patient are taking aspirin. Is there any secondary cause? Is it used for secondary prevention or not? Is it take for secondary prevention or primary prevention? If secondary prevention, the patient taking aspirin, restart aspirin, restart aspirin within 1 to 7 days. Okay, so what does it mean secondary prevention? If the patient has the risk of MI or stroke, so it is for secondary prevention, and we need to restart aspirin of 1 to 7 days after bleeding episode. But if the patient took aspirin for primary prevention, it is better to discontinue. Though Davidson, in Davidson there is mention the aspirin should be continued, but it is from in the Harrison, it is divided by this. In NSAIDs, discontinue, or we will provide COX-2 selective drugs. And in case of aspirin, if the aspirin is used for secondary prevention like risk of myocardial infarction or stroke, restart within 1 to 7 days after the bleeding episode. And if the patient take for the aspirin for primary prevention, it is better to discontinue. So there is a modified Blatchford score. Blatchford score is used before endoscopy to predict the need for the intervention of treat bleeding. So actually it means that the patient needs any endoscopic clips or endoscopic band ligation is need or not. So if the patient blood urea, so we have already know that the blood urea when rise, so it is severe bleeding, so we need endoscopic clipping. And hemoglobin, if hemoglobin falls more than 10 gram per deciliter, the score is 6. Is hemoglobin for women is more less than 10, then it is also 6. And systemic blood pressure is less than 90, so the score is 3. And the other marks is the presentation of syncope, then any hepatic disease, then score is 2. Cardiac failure, score is 2. And if the pulse is more than 100 beats, score is 1. Now we will discuss our last topic for today, lower gastrointestinal bleeding. Small intestinal causes for lower gastrointestinal bleedings are according to age. When the age is more than 40 years, the causes are vascular ectasis, neoplasm, which includes gastrointestinal stromal tumor, carcinoid, adenocarcinoma, or maybe lymphoma and metastasis, and NSAID-induced erosion and ulcer may occur. And when the age is less than 40 years, it causes are Crohn's disease, polyposis, and neoplasm. And in case of children, Meckel's diverticulum should be considered. And colonic causes, the most common causes are hemorrhoids and anal fissure. And other than anal causes, diverticulosis.
In case of diverticulosis, bleeding is abrupt, painless, massive bleeding occur, and diverticulosis is found mainly in right colon. And neoplasm and colitis may occur. There are 4 types of colitis: ischemic colitis, infectious colitis, Crohn's disease, and ulcerative colitis. There is a syndrome named Hayes syndrome. It is bleeding occurs from vascular ectasis when aortic stenosis is present. So our treatment should occur in the valve. And when valve are alright, then bleeding will be stopped. Severe acute lower gastrointestinal bleeding. The patient may present with profuse red or maroon diarrhea with hypovolemic shock. CT angiography should be performed to identify the site of bleeding, and if the site of bleeding is identified, we'll do catheter angiography, and if the source of bleeding is not found, colonoscopy should be performed. The commonest cause of bleeding is diverticular disease. Okay, so we need to do that endoscopic clipping with or endoscopic clipping either, or endoscopic clipping with adrenaline, or that means epinephrine injection is considered as first line treatment, which means dual therapy, as we mentioned before. Angiodysplasia should be considered in case of old and adult person, and if we do colonoscopy, it reveals characteristic vascular spots, and when we do angiography, we can see bleeding into the intestinal lumen and abnormal large draining vein. Endoscopic thermal ablation is the treatment. Bowel ischemia occurs in the inferior mesenteric artery occlusion, and we will consider bowel ischemia disease when the evidence of generalized atherosclerosis is found in the patient. Meckel's diverticulum is diagnosed by laparotomy, at which at the same time doing laparotomy, diverticulum is excised. Subacute or chronic lower gastrointestinal bleeding. Hemorrhoids and anal fissure are the most common cause. Hemorrhoids is bright red bleeding, occurs during or after defecation. Proctoscopy is done for diagnosis, but when the age is more than 40 years, we need to do colonoscopy to exclude colorectal carcinoma. And anal fissure is suspect when fresh rectal bleeding occurs with severe anal pain during defecation. Chronic occult gastrointestinal bleeding. Chronic occult bleeding means there is no blood can seen in the naked eye, but the breakdown product of blood is present in the stool. So it is sometimes when regular checkup or examination for another disease, chronic occult gastrointestinal bleeding is revealed. 200 milliliter per day cause iron deficiency anemia, and the most common causes are colorectal cancer and carcinoma of the cecum. So this is for lower gastrointestinal bleeding. There is a box from Davidson, the cause of lower gastrointestinal bleeding according to the severity. Severe acute bleeding occurs in diverticular disease, angiodysplasia, ischemia, Meckel's diverticulum, and inflammatory bowel disease in case of children, and moderate and chronic blood loss occurs in fissure and hemorrhoids most commonly, but other causes are inflammatory bowel disease, carcinoma, large polyps, angiodysplasia, radiation enteritis, and solitary rectal ulcer. Thank you.